Good afternoon, everybody, and welcome to this, the sixth and final webinar in a series that we at the Social Care Institute for Excellence have been running over this last autumn and spring on behalf of the Better Care Fund and the Better Care Support Team in support of their goal of integrated health and social care. My name is Hugh Constant. I'm a practice development manager here at SCIE, but I'm delighted to welcome Deborah Rozansky, who's an associate with us at SCIE, who will be running the webinar on metrics for integrated care. So we've done a number of webinars on some of the elements of integration, shared data, multidisciplinary teams and so forth. Now we will hear from Deborah about how you measure if it's working. So Deborah's going to talk for about 45 minutes to an hour, and as you listen, please feel free to ask questions in the chat box, which hopefully you can see in the center of your screen. And at the end of the presentation, I will kind of collate those questions and put some of those to Deborah. And so that's it from me. I'll hand you over to Deborah now.
Thank you very much. Welcome, everyone. Again, my name is Deborah Rozansky, and I'm an associate of the Social Care Institute for Excellence. And I've been working with the team here in developing ways to measure integrated care, the way we measure the impact and the way we know that care is improving. I've entitled my presentation, Metrics for Integrated Care, What Should We Measure to Know That Care is Improving? And to be quite honest, the answer isn't straightforward. So today I'm going to talk through how measurement is an emerging field, what we know for sure, what we're learning. I'll be combining some fresh insights from recent conference papers with some methods and metrics that we know are tried and tested and indeed offered by the Better Care Support Team. Oops. I'm trying to learn the ropes here as we go along. Here we go. The webinar learning objectives, which I've set out, suggest we first go back to some first principles. The first objective is to understand what good integrated care is expected to deliver. And I will explain a bit about a logic model that the Social Care Institute for Excellence has developed, including some of the underlying evidence that helped us develop the framework and how it might be used. I'll then talk through the types of metrics you might select for assessing the progress and outcomes of integrated care, from the use of management data to the use of national outcomes indicators. We will then review emerging tools and survey instruments you might use to capture data in near real time, or real time in fact. And then I'll provide you with a set of case studies to illustrate how others have used metrics to both chart their progress, build on what works, and accelerate change. I do have a number of slides, and you might find that I whiz through them. There will be questions at the end. We can go back to the slides, specific slides or topics you have particular questions about, so please take note of the slide if you'd like me to go back to it. Apologies because this one's a little bit hard to read on the screen here. Hopefully it's easier for you. There are a couple questions I think that would be helpful to get started. What I've described here is kind of a flow chart, if you will, about how to think about the metrics that you need, how to measure what is important to your local integration efforts. It does start back at square one, identifying what is your local integration ambition. It also helps you focus on what is the model of care and what are the interventions that you've put in place. From there, you can even develop your own logic models to identify the outcomes and impact that you want to achieve. What we will talk through today is how to do that focused on different parts of the system, not just the usual indicators, which suggest adverse outcomes in the hospital sector, but also how to measure such things as change in local services and the effects for service users. It's important to understand what we can measure to know we're improving. There's a lot that we don't know. Some of these areas are evolving, specifically around understanding user experience and carer experience. So I'll share with you some tools that help us come up to date with some potential ways to measure these things. One of the questions that we get asked repeatedly at SCIE is how we can use metrics to encourage or accelerate service or system changes, and we will address that as well. And then finally, we'll have a chance to talk through how you can create your own local scorecard, hopefully a balanced scorecard, to enable you to track your progress. There are a couple of things I just want to point out at the very beginning. In thinking about metrics, it's extremely important to focus on your local context. Understand what you're trying to do and why. Be clear about the interventions underpinning your local model of care and the evidence supporting these interventions. Going back to the evidence that's been published elsewhere can help you identify what to measure and how to measure it. And sometimes we don't take the time to do that. It's also important to differentiate between metrics that will measure performance and metrics that will measure progress or improvement. And I'll explain further how to do that differentiation and why it is important. And also, as I've said, what metrics are actually available? What might you need to collect yourself, but also which ones are collected elsewhere and routinely? The SCIE integration logic model has an interesting genesis. SCIE was commissioned by the Department of Health at that time, now the DHSC, to look at establishing an integration standard and how we might measure it. We went back and developed instead a logic model that tried to establish how integration would lead to better care, in particular for older people. We decided to focus on the person, in fact, person-centered coordinated care, as the real objective of integrated care, rather than integrated care being the objective in and of itself. So we asked the question, what is good integrated care? What is it expected to deliver? In the logic model, which I'll share with you in a moment, we illustrate how integrated health and care systems are structured, the changes they will create, how they will function, and the outcomes and benefits expected for service users, health and care services, and the wider health and care system itself. The logic model was based on research evidence, both from the UK and international evidence, extensive consultation and learning from some of the other pilots around this country, including the Vanguards, integrated personal commissioning, the integration pioneers, and other evaluation research. This approach enabled us to create an understandable framework for what good looks like and propose a set of metrics for measuring progress towards integration. A couple things to note when we come here, I'll show you on this. Here's the logic model. It's very difficult to read, but I'll tell you where to find it so you can look at it in detail. But for our sake here, it's important to remember that we were tasked with developing an integration standard for older people specifically, and that is the primary focus. We've had a lot of feedback about the model, about how it might apply to different population groups, and that is indeed possible. The logic model itself is not meant to be etched in stone. It can be modified for local use. And as I said, integration itself is not the goal, but the means to achieving better care and better outcomes. I will provide a web link at the end of this talk to the logic model itself and to the underlying evidence that SCIE published last November, I believe. So the logic model has 4 components. These will be recognized, I think, by all of you. The first is around enablers of integration. These are the contextual factors, such as leadership and governance, the partnership arrangements you have in place, shared IT systems and joint budgets, and a shared regulatory environment, as well as other factors. These, we feel, set the stage for integration to happen locally. The components of integrated care list the types of interventions and activities that create integration, ranging from proactive management of care needs to the effective behaviors of multidisciplinary teams. We don't expect that each local area will have every component of integrated care, but what we found through our research was that most places were doing most of these things. They weren't necessarily doing them all in the same way, nor to the same degree and to the same effect. But this is an aggregation of the interventions that are being used around the country. I'm going to go back to the logic model here just to point out one thing. You'll see a rather skinny little column. It may be hard to read, but it says outputs to your local activities. This is a skinny placeholder column, and it's meant to incorporate the outputs. What we heard from a lot of our engagement was that a lot of the pilots and a lot of the work that's underway also needs to measure what's happening on the ground, not just some of the outcomes. So that's merely a placeholder. But even though it's a skinny placeholder column, we think it's really important, and it is very significant to the talk today. The outcomes, as I've described, are divided into 3 groups. People who use services, and we include carers as well. The second is around integrated services in the wider health and care system. And the third is rather the wider health and care system. The impacts are the longer term impacts. And these are around health and well-being, enhancing quality, and providing best value. How has the logic model been used to date, and what has its impact been? We've heard that it's helpful as an on-a-page visualization of what a good system-wide integration, system integration arrangements could look like, and what they could achieve. What's missing, of course, are the metrics specific to the local interventions, as I've mentioned. It's a prototype, really. It's a framework for improvement, like a roadmap. It's not the be-all and end-all, but it does give local areas an opportunity for comparing what they're doing with what is considered a standard. What we're planning to do now at SCIE is create a digital resource that supports each of the elements in the framework. It will signpost people towards the evidence, provide case examples, tools, and resources relevant to each. The prototype is in development, and we expect to produce it probably in the next 6 to 8 months. Now, the logic model has been used as a tool to inform a number of other national initiatives, including the CQC's local system reviews, the NHS Standards Board, and a cross-government integrated care program board. More recently, it's been informing national policy discussions around the upcoming social care green paper. Commissioners and integration leads have largely welcomed the model. In some places, the model has helped guide the development of local dashboards. For example, we recently heard about this from Wokingham. Many of the outcomes metrics in the model were proxy measures, or they presented caveats. As I said later in this talk, I have a link that will point you directly to all of our research. It's a much longer paper where we dissect all of the different metrics, what you can use and what they mean, but also what their drawbacks are. We are updating our research right now, and we're looking at additional international evidence as well as UK programs. Some of the more recent international evidence, and indeed some of the results from the Vanguards evaluation, I will report on today, so you will be very up to date. So these were the metrics that we included. I'm not going to run through all of them here, but just to say that it's a mixture of quantitative and qualitative measures that we suggested to measure all of these different outcomes. There are gaps in measuring people's experiences with integrated care, and those of you who have been doing this for a while will know that. There are some proxy measures, there are some national indicators, however, a lot of them are not very timely. For example, the GP patient survey has questions about people's involvement in care planning. Unfortunately, that measure does not capture holistic health and social care plans. There are also methodological challenges when you survey a whole population that has not specifically received integrated care. So we can delve into some of those details a little bit later. The outcomes also don't really enable you to collect data for improvement, and that is data that's best collected in real time. So some of the ways of doing that are through other survey instruments rather than national data sets. And finally, it's very difficult to demonstrate financial benefits and outcomes and how to measure these. There are some approaches that are in development. There's some interesting work in Europe, which I will share with you. So The logic model is only a starting point. What we know about integrated care, what we can measure, are evolving, and recent studies confirm a mixture of quantitative and qualitative metrics is essential for knowing whether or not you're making a difference and whether or not you're making progress. We need to differentiate between metrics for performance management and metrics that support improvement and accelerate change. We need to understand what can we measure in real time and how do we do this. And finally, there is an old adage to understand that what gets measured gets done. So sometimes when you include a metric in a dashboard, that does create a priority for local people who are trying to put those changes into place. Another example of that is the delayed transfers of care metrics, which are a policy priority. It has diverted attention from some of the other aspects associated with integrating health and social care. So I'm going to breeze through some of this area here quite quickly, but there will be a number of links that will take you to the additional evidence. There's some really useful learning from international evidence from recent conferences. There was an International Foundation for Integrated Care conference a few weeks ago, and last week from the European Healthcare Management Association. All of the papers presented about integration at these recent events, some of which have been published through the Integrated Care Journal through the Federation, confirm that integration is a journey. It involves a lot of system, process, and behavior change, and those are not easy things to measure. Unfortunately, we can only measure what we can measure. So what we'll do right now is run through some of the learning from the Vanguards and Pioneers, which are closer to home. I hope you can read all this. It's dark on my screen here. So the Vanguards were the new care models, and they've been underway for about 3 years. There were important lessons from the early evaluation. The final evaluation is still underway, but I will share some of the highlights from it. The first thing is, again, as we all know, integrated care is multifactorial and partly dependent on a number of factors. Number one, the maturity of the health and care system, or what we in the SCIE framework call the enablers. So how do we measure the maturity of the health and care system? What can we do to understand if that's changing? The second is really taking a closer look at the system's incentives, especially financial incentives, to reinforce the behaviors supporting integration. The third is prioritizing personalization and co-production as drivers of change. So how do we understand if that's actually happening in reality? And the fourth is the clarity about what is being integrated. Which services and ways of working are being integrated? Or are we actually talking about delivery systems and cross-organizational working? So some of those things will require different approaches to measurement. And being really clear about that is extremely important. These are some of the lessons about measurement from the Vanguards evaluation more recently. Again, some of this is not yet published, but it is very important learning and relevant here. The Vanguards were all very different. Only about 50% of them were integrated care models. Some of them looked at interventions in care homes, and others were much more focused on primary care and in the integration of organizations themselves. So there were only really 2 core metrics that they were measuring across the whole Vanguards program. One was total bed days, and the other was emergency admissions. They're now looking a bit more carefully at not just emergency admissions, but emergency bed days. What they found was that the meaningful aggregation of data at the system level is very difficult because care and care processes vary across small areas, such as the GP practice level, either at the neighborhood level or sometimes across localities. So what that means is that data that you might be collecting on a pilot basis, when you try to build it up into a bigger picture, becomes less meaningful. And they've also confirmed that national survey data about patient experiences is not very timely or helpful in trying to understand overall impact. However, it was extremely helpful in understanding whether the interventions put in place were starting to make a difference. The other thing that they found was that they cannot yet confirm causality of different interventions in relation to the two core metrics, bed days and emergency admissions. That doesn't mean what people were doing was the wrong thing, but they haven't been able to determine causality. It could be that the metrics that were selected were the wrong ones. What they did say was that there were hundreds of operational metrics being used by the different vanguards, with some obvious clustering around different topics, but they vary greatly in their reliability. Essentially, a lot of the vanguards, as they were implementing their changes, were involved in a lot of rapid cycle improvements and using tools that were relevant for that approach. However, there was no single approach that they used. So some of them used agile approaches, some used PDSA cycles, etc. But that was the main approach. They were very focused on what might fall under the umbrella of change management. All in all, the vanguards, the people leading them, found that collecting and analyzing data for management information is useful for focusing on improvements at locality level. So I would suggest that that same approach is still relevant for integrated care around the country. Across Europe, there have been some very interesting approaches to trying to understand how integrated care is being implemented. This is a model called the Scaling Integrated Care and Context Maturity Model that's been produced for the EU. It's similar to the enablers of the SCIE logic model. It includes looking at things like readiness to change, structure and governance, information systems, etc. Accompanying the model is a self-assessment tool that local areas can use to assess their own maturity. And it reports the findings in sort of a spider web format. It may be something that you would want to consider using to test your starting point now and to set some goals for system maturity. The web link, I believe I've got it at the end, but if not, it's scirocco-project.eu, scirocco-project.eu. This is, here the Integrated Care Performance Assessment is a comparative study across the 28 EU member states and more. It was commissioned by the Consumers Health, Agricultural and Food Executive Agency of the European Commission. And this is quite interesting because it's a framework model that has produced 18 core indicators for assessing successful implementation of integrated care. It focuses on 4 core areas: the advancement of integration, the use of care services, health outcomes, and experiences of care and quality of life. They've also looked at metrics associated with each of the core indicators, looking at what's collected nationally across all of the European countries. In addition, they are developing a way to monitor and assess the allocation of funds and how that links to performance of integrated care, and thus to provide a financial evaluation to inform future expenditure decisions. When that's developed, it might be useful for commissioners. This was reported at last week's European Healthcare Management Association's conference in Budapest, and there is an upcoming webinar about it, which I will give you details about at the end. A third project that does involve pilots in the UK as well as across the EU is called the SUSTAIN project. And SUSTAIN stands for Sustainable Tailored Integrated Care for Older People in Europe. It's focused on care delivered to people living at home with multiple health and social care needs. There are 2 sites in the UK as well as researchers who are involved in the project. The main goal of this project is to try to understand how to transfer successful initiatives to other regions and health systems. It also focuses on 4 areas that are very similar, although not entirely the same: person-centeredness, a prevention approach, safety, and efficacy. Most important, it emphasizes how local areas are collecting data for improvement and it uses an embedded case study approach. There's some interesting validated tools that are being used in this project, such as P3CEQ, a team inventory, and another one which I didn't mention here, which is also looking at how organizations are working together. We'll delve into some of these tools and where to find them in a moment. So if we were to look at integrated care through a kind of a simpler overarching framework, we would look at the system capacity and use of resources, which is really the supply, if you will, against the proactive model of care and how services are being used, so how activities are addressing demand for services, and then the processes involved that are going to deliver better personal experience of care, including focusing efforts on coordination of care and continuity of care. I was asked recently what would be kind of the best buys in integrated care, what would really accelerate change. And looking back at the evidence, we determined that there were at least three things. The first was to really focus on those processes and activities around care coordination and continuity out of hospitals. So what's happening in community settings, at home, involving primary care and preventative services. The second is around those processes and activities that focus on care coordination and continuity during transitions of care. And the third is looking, trying to tackle the barriers to integration at a system level, but also thinking very, very carefully in terms of capacity around people. Who's delivering integrated care and how well supported and trained are they? In terms of change processes, these are the things that I'd like to suggest you would focus on in addition to interventions. How well you're laying your foundations. How much progress have you made in maturity of your system, focusing on leadership, your strategy and resources, the digital records, or the interoperability. How are these happening in your local system? Are there ways of testing how well the relationships are forming, not just across organizations, but across teams and involving patients and carers? How well do you know if care is actually changing in terms of its delivery model? How well are you delivering patient-centered care? Is it proactive? Is it the right care in the right place? And how well are you able to identify and indeed reduce those barriers to care around care coordination in particular and in terms of access across 24/7? Very briefly, this is, some of you will be familiar with this from the literature. This is Meatman's development model for integrated care. And I've thrown this in merely to, again, emphasize that care arrangements that are integrated are very complex to organize and to deliver. It's an iterative process of change. So what we need to measure is also how well you're advancing over time. Most of the integrated care across the UK, and indeed probably worldwide, is only really in that sort of phase 2 to phase 3 place. A lot of it's still experimental, just being executed, or if it's made some progress to expand, it hasn't quite been scaled up. And this is just an example of the PDSA cycle. Again, my point here is that continuous improvement is the method. It's not that you do it once and that it's perfect, but you need to be able to measure things over time, and there are ways of doing that. I put this here. This is a guide that was produced by, for the Better Care Support team a few years ago, but it's extremely relevant. It's very solidly researched. It includes a lot of sound practice about how to understand and measure impact. So I suggest you take a look at it because it's relevant still. It includes a number of approaches and exercises that you can use with colleagues locally. So what are the sources of data and their benefits and limitations? We tend to look at what's collected on a routine basis through national data sets and surveys. Some of the advantages of doing that is that, of course, they're collected and reported already, so there's no additional burden or cost for collecting them. Metrics are generally understood and they're already used to judge system performance. They also include a number of health indicators, and you can track change over time. The disadvantages, however, are important to understand. They're not necessarily timely or focused on people receiving integrated care. And that raises a number of methodological issues in knowing whether or not you're making progress. The system measures that are used nationally are often equated with acute care outcomes. But we know acute care outcomes have multiple influences. And as we've learned from the Vanguards, some of those, we can't establish causality between certain approaches to integrating care and changes in the acute sector, even though they are emphasized. The other thing is that the metrics that are collected nationally are not necessarily assessing integrated care per se. Local indicators would be drawn from validated tools and instruments. The advantages of doing that is that they're program-based or project-based. Often they're qualitative, so they're based on surveys and sort of ways of gathering immediate feedback. They're most useful for testing interventions and for making improvements in rapid improvement cycles. And they include a lot of process measures, so not as many outcome measures. They're very operational in focus. In fact, as I've said with the Vanguards, where they had hundreds of operational indicators that they were looking at, or metrics rather, that would apply here. It doesn't mean that they're irrelevant, however. The drawbacks are that they require you to collect the data locally and in some kind of systematic way. There are problems in aggregating the data. Sometimes the information you collect is only relevant to a small project or group of people. It's not necessarily scalable, so you have to be aware of that. There may also, as I said, be problems with determining causality. Nonetheless, what we're suggesting here is to combine both national indicator and local indicators to understand what you're doing. So what might you include? Looking again at the enablers, or the foundations for integrated care, you might want to use self-assessment tools like the local government associations stepping up to the plate. I understand that that's going to be updated very shortly. Or the tool that I mentioned earlier, the Scirocco tool, which looks at the maturity of your system. You can use that to baseline where you are and to track progress over time by reintroducing the tool, perhaps every 6 months or annually. The CQC, in its local area reviews, has also been piloting the use of a relationship audit. It's been found to be very interesting and quite useful in understanding how all the different players in a system are relating to each other at an organizational level. It tests a number of assumptions that people have about how well those relationships are and what needs to be strengthened. Also, I wanted to suggest the high impact changes, because a lot of those do focus on system enablers. And there may be other things you want to use, such as a digital maturity audit, and there are a number of those available, which we could share. Looking at care coordination and joint working, and as I said, this is an area to really emphasize, because we think that by focusing on that and measuring care coordination, you will be able to test whether or not you're making a difference in putting change in place. One of the areas of focus would be the multidisciplinary teams, and I know there's been another webinar about that. So measuring change is also often combined with sort of support for team development. You can identify what the strengths and weaknesses are with teams and then also couple that with support. Successful joint working can also be assessed by looking at skills and knowledge, effective communication, trust and behavior change. And we can also assess how organizational support and infrastructure support team working. So some of the tools that are available, as I said, require some additional external support. You've heard was at the University of Birmingham, also does work in this area. There's a team effectiveness tool. I'll show you where to find that. That's being used by the SUSTAIN project. There's also a tool they're using in SUSTAIN that's looking at practice development across organizations and how some things like data sharing are perceived by the teams who are delivering integrated care. Measuring user experiences. This is the area that is probably the most difficult, the most emergent. The data are mostly captured through surveys. The national survey data may not be specific enough to the groups experiencing integrated care, which raises a number of methodological problems. So what I'd like to suggest here is that in addition to looking at those indicators, you also consider how in your local interventions you might apply some of the other short surveys to baseline what's happening and to check progress over time. There's some interesting work that's been compiled by the Southwest Academic Health Science Network with Plymouth University around person-centered coordinated care. I'll show you that website in a moment, but one of the things that they seem to be promoting is this tool called the P3C-EQ, and it does capture the experiences of people with person-centered coordinated care. Another one is focused on care transitions. They also have one on care experiences. Some of you may be familiar with the patient activation measures. That's quite popular, especially with GPs and working in primary care. It helps identify which patients are actually more capable of self-management. It assesses knowledge, skills, and motivation. It's also a way of testing whether or not the interventions are making a difference in that regard. There are a couple tools that haven't been specifically adapted for use in the UK, but I would like to suggest that you look at them as well. They were designed specifically for measuring patients with chronic care needs. If you look at them, what's quite interesting, it's called PACIC and ACIC, or PACIC- or ACIC. Those tools have kind of a maturity model embedded within them. They can, by answering questions through a self-assessment tool, you can identify where you are and what you need to do to improve. And it sets some standards around the management of care for patients with chronic care needs. Paper here. Again, this may be hard for you to see. This is the website that I've mentioned from the Southwest AHSN and Plymouth University. It's called Measures for Person-Centered Coordinated Care. And if you go to this website, you'll be able to find a plethora of tools that you might want to use and look at. The evidence base is there as well. It's not just where to find the tools, but it talks about what those tools can be used for, why you might want to test them out. If you go to the short list, which I've highlighted here, you'll see that they've separated the tools into different categories. For example, broad measures of person-centered coordinated care, measures for goals and outcomes, measures for care planning, measures for information and communication, measures for transitions, and so forth. These correspond to the National Voices I statements, and those are the green tab, the turquoise tabs rather. The green tabs highlight disease-specific measures. There's a lot of repetition across them, but it's a useful way of getting into what they have on their website. In addition to tools that focus on patient-centered coordinated care, they also include ways of measuring quality of life. To use the P3C-EQ tool, you have to register, but the tool is freely available. It has either 11 items or 13 items. The care transition tool, which I mentioned in the previous slide, has 3 items. So these aren't exactly long surveys, and they're very useful for capturing information. This is where you can find the PACIC and ACIC tools. This is from the McColl Center. It was Group Health Cooperative and Kaiser in the US. They set up an initiative around improving chronic illness care, and this is where you can find those tools. This is just a list of some further things you can do. I won't go through it in detail in the interest of time, but it's a useful summary for you. The most difficult thing to determine is value for money for interventions. The evidence from the international studies suggests that savings are highly dependent on providing services to people who are most likely to benefit from them, i.e. people with chronic care needs. So the evidence is emergent, it's not definitive. There's a study I found from Geisinger, which is an integrated health system in the US that estimated 6 to 7% savings in hospital spend after several years of their program of chronic care. But that was after several years. More recently, some of the Vanguards have suggested some savings, but those aren't necessarily the integrated care Vanguards. They're more focused on the interventions in care homes. We're often asked to look at admissions avoidance, and that's extremely hard to record. So you need to look at trends across the whole target population group. Anyway, this is a very complex area, and as I mentioned, a tool is being developed that might be useful through the International Foundation for Integrated Care, but it's not quite ready yet. Actually, it's through the EU and the foundation. When that's available, I'm sure we can promote that. Nonetheless, there are some potential things that you can look at least try to judge in the interim whether or not there is a financial benefit associated with integrated care. The Vanguards are demonstrating some good performance in reducing emergency admissions. They're now looking at emergency bed days, but they're delving into it not just the number of days, but the number of days for admissions that are more than 1 day. As I said, the care home Vanguard, particularly the one in East London, was evaluated by the Nuffield Trust, and it showed a reduction of 36% in emergency admissions, and bed days following emergency admission fell 53%. That was amazing, actually. None of the other Vanguards, I think, came up with the same kind of results, but it was significant. You can find details of that on the Nuffield Trust website. Other hospital data that you can be looking at, which is routinely collected, in addition to what I've described above, is unplanned care, bed days, length of stay, and delayed transfers of care. And you'll be familiar with those things, I'm sure. We often think that also looking at readmission rates can be quite helpful, especially if patients have been discharged into social care. It's a measure of whether or not the social care is enabling people to stay out of hospital and to rehabilitate them. Another area to look at is the costs associated with medicines. So here we are. We're going to come back to how we might build our dashboard. I'm not going to run through this again, but think of the steps. Understand what you're doing and why. Understand what the metrics are actually going to tell you, whether or not they're valid metrics and what the caveats might be. How to mix both national and local indicators, how to mix quantitative and qualitative measures as well. The other thing that I would say is that you might want to mix performance data with some of the improvement data that we've described. My rule of thumb is that less is more. Remember, what gets measured gets done. So if you have too many indicators, you lose sight of what's really important. And metrics can change over time. You can start with a dashboard, and as you make progress, you can change them. There's no reason why they have to be etched in stone. Ultimately, the data have to be really meaningful to the people on the ground, not just people who are judging performance. They should be easy to collect, reliable, affordable, and readily available, real time if necessary. For the local metrics, what I suggest is you can go back to your own logic model or the SCIE logic model and refine it over time. You can use agile approaches or continuous quality improvement cycles to do small tests of change to see whether or not, on the one hand, you're able to measure those changes, whether you're measuring the right things, and whether you're making progress. You can measure those outputs. Those are really important. The operational outputs are just as valid as the good outcomes and the poor outcomes. But there may be some things that you also want to keep sight of. So, for example, falls. Adverse events like falls can be an indication of whether services are actually doing what they're supposed to do. So if the services, for example, are trying to keep people at home and as independent as possible, an older person falling is an indication potentially that the interventions have not made a difference. We need to also monitor improvements over time, and that is quite difficult, but it can be done. So what type of standard of data or evidence is needed? Again, this is a little difficult to read. I hope you can read it better than I can. This is from Nesta. This is about using research evidence and putting it into practice. And I pose it here because if you look at the sort of bottom rung, level 1, this is data that you can describe, that you can use to describe what you do and why it matters. And it's logical, coherent, and convincing. And that's where you need to start. The second level is when you capture data that shows positive change, but you cannot confirm that you caused it. I would venture that most of the data we capture around integration is probably at this level. The third is that you can demonstrate causality using a control or comparison group. It would be great to achieve this with integrated care, but that's, I think, where the state of the art is. We're not at that stage where you can replicate efforts quite readily, and that you have manual systems and procedures to ensure consistent replication. What we see at SCIE and elsewhere is that local areas are doing a lot of good work, but it's still very patchy. There might be one area of a local borough, for example, doing really great work with their multidisciplinary teams. But in another neighborhood, it's not working the same way. So the innovations that have developed in the first area have not translated into the second. And that's on a very small scale. When you try to think of that nationally, there's a tremendous amount of variation. And that's okay. But it doesn't, we have to be very clear what it is we can measure and what we're capable of measuring. We're not at a place where we can systematize what integrated care is supposed to be. And I think part of that is because if we focus on patient-centered coordinated care or the service user, we're talking ultimately about people who have different needs. And if we personalize integrated care, we're going to necessarily have that variation. So this is just a brief example of what a dashboard might look like, balancing sort of hard and soft indicators and the metrics to measure them. I've used the structure from the SCIE logic model here. So the first is around measuring service users, carers, and their experiences, then looking at the quality of services and service delivery, and then the system effects. Again, and then the system enablers, so what's working might get in the way. Again, this is an attempt to balance quantitative and qualitative metrics, national and local data sources, and performance reporting with improvement data, looking at things like the real-time capture of how teams are working, or the real-time experiences of patients with or service users with care planning and coordination. So that's just a very short approach, but it picks up on some of the main things that we found really make a difference. Here are a couple examples, case examples of what people are doing. This is from one of the Vanguards. This is the Dudley Vanguard, and it includes indicators and metrics for person-centered care. And I've included it here because I think it's a very good example of where the measures clearly identify what they're trying to do, how they're going to measure success, and what types of indicators and evidence they're going to use to determine how much progress they've made and whether they've achieved that success. It's very detailed, but it's a very useful format for bringing in the metrics and connecting them to your change objectives. Here's another case example that looks at the operational or process indicators. This is from the EU Sustain project, and it also brings together another project from EU called the Advancing Care Coordination and Telehealth at Scale project, both of these funded by CHFIA. It has information about the population. It's looking at numbers and percentages, so things that you can quite quickly capture, like the number of care plans with activities being actioned, not just whether or not you have a care plan, but whether it's actually been followed through. So some of these might be very tick boxy, but still extremely important. And you can establish what's the most important thing to assess from an operational standpoint. This is the core indicators that I suggested from Jafia, which had 18 core indicators. I made a slight mistake on this slide, so I will correct it as we speak. Under health outcomes, there should be a third bullet that says improvement of health outcomes relevant to integrated care. But there were 18 indicators that they identified. And how this works with the metrics is that local areas can use the metrics to set a baseline and then self-assess through the framework, set a target, and then remeasure using the same assessment tool. This tool has been now tested around Europe and is available. So I'll let you know how to find more information about it in a moment. The tool that hasn't been finalized is around how to assess the allocation of resources and the financial data, and that will hopefully be available very shortly. Here's another case example, and this is from primary care. The reason I put it here is because there's a whole other set of developments that have been underway through the National Association of Primary Care. Led by a lot of GPs with a lot of enthusiasm and energy, they're taking forward what they call the primary care home pilots. This dashboard looks at the use of resources, the things that were obviously of concern to the GPs in implementing a lot of proactive care in primary care. And with the way local strategies are developing, there's a convergence between the policy objectives of integrating health and social care with the proactive approach in primary care. A lot of the STPs and other local area strategies are focusing on locality work that brings all of that together. So this is interesting because it's very focused on resource use. It looks at, as I said, A&E attendances, admissions, GP referrals, prescribing costs, and so forth, as well as GP waiting times and other types of health measures. I wouldn't necessarily suggest what they've done is correct, where they've aggregated the evidence from a wide range of pilots to demonstrate the impact, but it is a useful example. And if you go to the National Association of Primary Care website, you'll see how many of these pilots are underway across the country. And their proliferation, I think, is an opportunity for local integration efforts to connect with them. Because they have a lot of GP support, I would recommend building in some of the pilots into the integration efforts. So where do you go for more information? This slide includes links back to SCIE's website. The first is the paper that we produced, that we published in November last year about the integration scorecard, really the framework. And it includes details about the metrics as well as the evidence underpinning the logic model. And then you can go also directly to the logic model for the second link. And quite briefly, this is just, again, where you might be able to link to further resources. The first one is the BCF user guide, which I mentioned, how to understand and measure impact, extremely valid, hopefully not forgotten. The second is the website for the person-centered care coordination tools. The third is to a paper produced for the EU on tools and methodologies to assess integrated care across Europe. And then I'm going to put a plug here for another webinar that's coming up on the 12th of July from noon to 1 o'clock through the International Foundation for Integrated Care. That will be picking up on one of the tools, a system health check, and the toolkit associated with it. I highly recommend that. And then there's the Scirocco online self-assessment tool, and you can find it through that link, as well as some videos about how to use it. And then for those of you who are interested, you can also look up the McCall Center for Healthcare Innovation. Those tools that I mentioned around chronic care management were interesting because they incorporated a maturity model in their assessment tools. So here we are, questions and discussion. Thank you so much for listening as I breezed through what seemed like a lot of slides.
So yes, I mean, if you have questions for Deborah, now would be a great time to put them in the chat box. Whilst we're waiting, if I could use Chair's prerogative and ask one myself. This is about how to measure integration and the use of data and metrics to do so. In your experience, is there a difference in attitude between the two parts of the system, between health and social care, in their degree of comfort, I suppose, with gathering, analysing and using data?
Is there a difference? It depends on who you talk to.
Okay.
So I think how I would differentiate it is how are the metrics being used? What is their intention? So we tend to focus on performance indicators, but that's very top down. So what I'm suggesting here is that we also need to think about the bottom up and the sort of information that we collect that will help us know whether or not we're making a difference, whether things are improving, and whether we're really embedding the changes that over the long term are going to make a difference, such as around care transitions and care coordination, for instance. And whether or not, I think ultimately, the true test of integrated care is whether or not the service user is experiencing a seamless experience.
Yes.
You know, you go back to the National Voices I statements. We don't really know how to measure a lot of those things. People have tried to ask questions about integrated care specifically, but for people experiencing care, that's sort of meaningless to them. They just want to know that they just want to talk about the overall experience.
Because if integrated care is really working, people might not even know that what
They
they're
are not supposed
experiencing is integrated care. Yes,
exactly.
Absolutely.
Exactly. So I guess it depends on who needs to know. And I think in trying to assess whether or not your local system is improving, you need to think about it both top down and bottom up, in which case you need a combination of indicators. And that's why the dashboard that I'm suggesting here, based on the SCIE logic model, would include both approaches. As long as you're clear what you're measuring and why, and how you're collecting the data, and people who are implementing the changes understand it, as well as those who are monitoring the changes understand it, you should be okay.
Question here from Stephanie Patterson. Are there any other tools we can use which don't require the use of a control group to identify causality?
I do not know. At this stage, in integrated care, it is, as I said at the very onset, this is an emerging field. If people do know tools, please put them up here. What I would suggest is that you go to the tools that have been validated in practice. So that means that they're meaningful to the people who are using them as indicators. They're meaningful perhaps to service users, and they've been well studied and well published. The evidence that we use to compile the logic model, as I said, that evidence also has some very interesting indicators. The most difficult thing around causality is that the types of things we're often looking at are multifactorial. So even the Vanguards have had a difficult time in measuring whether or not all the interventions, the new care models, have made a difference to bed days or emergency admissions. I think this is an area that we need to continue to research and develop. But if people have some good ideas, let's share them.
And two very interesting questions here, I think very important questions from Carl Griffith. We do, I think he's right, tend to think about integrations between health and social care, which brings its own complexities. But what about the voluntary sector, police and ambulance? And what's the role of the person in this? Do we have tools where they're a genuine partner in this measurement?
Well, again, that's why I would suggest you go to this P3C website that I suggested. There was, initial investment through the Southwest AHSN and Plymouth University, where they have combined a lot of tools that focus on the user experience. The tools themselves don't necessarily need to apply just to statutory services. I can't see why, if you're taking a whole system approach, you couldn't involve the voluntary sector or housing or other types of providers of integrated care. The tools are not specific necessarily to a single environment, but they are intended to use across systems.
And Joss is asking, why not use a social network analysis approach to this area?
I don't personally know a lot about that approach and the advantages and disadvantages of using that approach, but I certainly wouldn't reject it without understanding the evidence. It may be appropriate, so why not?
Yeah.
Let's share it. I mean, that is what the BCST is for. It's for the platform is for sharing some of these tools and how people use them in practice. So I would encourage you to do that.
Well, we are at 1 o'clock. There are signs of potential other questions coming through. Just going to pause to see if any more come up. Otherwise, we might start to wrap this up.
Yeah.
And as you can see, Deborah has very kindly shared her contact details, so you can put questions directly to her.
I'm happy to carry on some of this conversation either on the BCST platform, or you can contact me directly. I hope this has been helpful to you. I hope I've set you on a course to find some useful tools, as well as helped you understand the types of metrics that you can use in practice.
So just to quickly answer those two last questions that come in, Melissa, I can answer your question, is that they're all on the SCIE website and hopefully reasonably easy to find once you get there. Stephen, I don't know the answer to that question. Do you, Deborah, about the social care interface dashboard?
I do not.
Okay.
But that's something we probably need to find out about.
Yes, no, Stephen, we will try and find out that answer and get that to you, okay? So yes, that you'll see a quick evaluation. Thank you to Deborah, thank you to all of you for staying in on such a lovely sunny lunchtime and engaging with this. It's been a really interesting discussion. So, and as I should have mentioned at the beginning, it will appear on our website a few days hence, a full recording and the chat box and so on. Okay, many thanks.